Hello, good morning. Today's topic is sulfonamides. I think you must be knowing that sulfonamides are the first antibiotics to be known. Before that, the mortality due to infections was very high till any antibiotic or drug really effective against these infections was known. And historically, these drugs are very important. How they were discovered is also very interesting, that somebody was working with some azo dyes, and just by chance that it was observed that some of the animals who were infected with septicemia or streptococcal infection, they were saved because of this dye, and even a child was also saved out of infectious condition which otherwise would have led to mortality. So it was interesting to know that these azo dyes had some property that they protected living beings from the bacterial infection, and did not allow the mortality to take place, and people recovered after using these dyes. And it was soon found that these dyes contain some moieties which are sulfur drugs related, and these moieties is the active moiety which produces the beneficial effect in these antibiotics. So these were the first effective therapeutic agents that were known, and it was a really big thing to happen because with the availability of these drugs, many deaths could be prevented because of infections that have been taking place, since nothing else was available to save the people. So now, when the active moiety was known in these azo dyes, that the dye that was being worked out was Prontosal. So this was found to contain sulfur drug, and these sulfur drugs are structural analogues of para-amino benzoic acid. So when their structure was soon known, and it took about 35 years to get to know the structure and get the compounds identified with the activities. Now, Prontosal dye is the azo dye which contained the sulfur drug or the moiety resembling para-aminobenzoic acid, and these contain sulfonamides. Now, these were, as I said, that they protected mice with streptococcal infections, and even a child could be saved because of infections. And the active moiety or metabolite that was produced by these agents was sulfanilamide. So this was effective in sepsis and meningococcal infections. Now, see, these drugs were found to have broad spectrum. They were antibiotic and possessing bacteriostatic effect. So they were bacteriostatic. That means they do not allow the bacteria to grow, and the the problem that later was obvious from the use of these drugs was that resistance developed to the use of these drugs, and that was the major problem. Otherwise, these drugs were wonder drugs when they were available. Now, in vitro, if you look at the microorganisms that were susceptible to the action of these sulfonamides, these include streptococcal pyogens, Streptococcus pneumoniae, Haemophilus influenzae, Nocardia, Actinomyces, and Chlamydia. So many organisms were found to be susceptible in vitro. And if you look at the compounds which were available, you see there are certain sulfonamides which are absorbed easily and are excreted out also rapidly. So this is sulfisoxazole, sulfamethoxazole, sulfadiazine. So look at the half-life. Sulfisoxazole is having half-life of 5 to 6 hours. Sulfamethoxazole has half-life of 10 to 11 hours. Sulfadiazine also has a longer half-life. Then you have compounds which are poorly absorbed. If they are poorly absorbed, they are locally active in the bowel lumen. So this includes sulfasalazine. Then you have drugs which are typically used, So they need not be absorbed. They are applied on the surface and they act when applied on the surface. This is sulfacetamide, silver sulfadiazine, and mefenide. So these are topically active, applied on the surface. And then you have long acting sulfonamide, that is sulfadoxine, which has a very long half-life. Now, what is the mechanism of action of these sulfonamides? Since they are analogues of para-aminobenzoic acid, so they act on the pathway which leads to the synthesis of folic acid. Now, folic acid is being synthesized by the microbes, whereas in eukaryotic cells, it is the preformed folic acid which is being utilized. So, when the synthesis takes place with the help of pteridine and para-aminobenzoic acid, that happens in microbes only. So you have enzyme dihydropteroid synthase, which this conversion of pteridine and para-aminobenzoic acid to dihydropteroic acid is inhibited by sulfonamides because they inhibit the enzyme dihydropteridine synthase. So they do not allow this conversion to take place, and then this dihydropteroic acid is converted to dihydrofolic acid, which subsequently gets converted to tetrahydrofolic acid by the action of dihydrofolate reductase. So you have another drug which is available, which blocks the conversion at this level, inhibits the conversion of dihydrofolic acid to tetrahydrofolic acid. This is trimethoprim. So you see, first step is inhibited by sulfonamides, and the second conversion, enzymatic conversion, is inhibited by trimethoprim. And you have combination available. We'll talk about this, that you combine these two to produce a sequential block, and to produce a sequential block and the combination is more effective. Now, when such a mechanism has been worked out, how the resistance develops to the use of sulfonamides. So it has been shown that the affinity of the enzyme changes. So enzyme that converts pteridine to dihydrofolate, dihydropteroid synthase, the affinity of this enzyme changes for sulfonamides. So if affinity is reduced, the inhibition doesn't take place and the pathway continues. Or the microbes, they tend to produce more amount of para-aminobenzoic acid to just overcome the inhibitory effect of sulfonamides. So more substrate is available, more chance of having a product is there. There may be decrease in bacterial permeability or active efflux of the drug. So the drug is being removed, constantly removed because of active efflux. So thereby the effect of drug doesn't last longer and the pathway continues. Or there are alternative metabolic pathways for the synthesis of metabolites that happens in most of the organisms, might be happening, that leads to resistance to the action of antibiotics. It is also possible that plasmid mediated resistance also takes place, and which is due to plasmid encoded drug resistant dihydropteroid synthase. So the enzyme is resistant to the action of the drug and the blockade of the pathway doesn't take place, or they do not confer cross resistance to other class of antibiotics also. So that means if a resistance develops, I think one has to be careful in using these drugs alone as such to get the benefit of using these drugs in preventing the microbial resistance. Now when we look at the pharmacokinetics, the drugs which get easily absorbed, they get absorbed in the small intestine, and absorption is quite good. 70 to 100% of oral dose that is administered is absorbed. They are well distributed also, since they bind to the albumin in the plasma. So as a result of this binding, their effect lasts longer. So they become long acting because they are slowly released as and when required, and they remain in the plasma bound form. These drugs are widely distributed, and they are distributed to pleural, peritoneal, synovial and ocular fluids. So that means their distribution is quite good, and their efficacy at these sites is also because of their distribution at these sites. Sulfadiazine and sulfoxazole are effective in meningeal infections also. So more or less, when you look at the spectrum of these drugs as well as their distribution in the body, they look very good as far as their effect is concerned. These drugs get metabolized in the liver and mainly because of acetylation. So they undergo acetylation and their properties change and they form the metabolites which are inactive. Now, what happens when these sulfonamides get acetylated? So, depending upon the pH, their excretion is determined by the pH of the urine. You see, in the alkaline pH, you see their renal clearance is accelerated. So, if pH is alkaline, they are the acetylated sulfonamides are easily excreted out. But if the pH is acidic, you see they tend to form crystalline deposits and which may cause urinary obstruction. So one has to be very carefully seeing that. So as a result, new products have also been developed where the pKa or the acetylation or the pKa or the ionization of the drug is uh, different, so that it can bear with the change in the pH of the urine. So, but as far as the available products are concerned, you see crystalline deposits are very common if the pH is acidic. Now, excretion of these drugs majorly takes place via kidney, or small amounts which do not get absorbed are excreted out in feces. Some is present in bile as well as in the milk. Now, where these drugs are used? These drugs are effective in urinary tract infections. Sulfoxazole is used when the organism is known to be sensitive. So that means one has to check for the sensitivity, in vitro sensitivity to the drugs, and if sensitivity shows that it is this particular microbe is susceptible, one can use this drug. So sulfoxazole is used when organisms are known to be sensitive. The initial dose is 2 to 4 grams, followed by 1 to 2 grams orally, 4 times a day for 5 to 10 days. Now, patients with acute pyelonephritis should not be treated with sulfonamides, as we just have seen in previous slides that there is chances of crystal deposit is very high, and the kidney gets damaged because of their deposits. Now, the drugs can be given in nocardiosis. Sulfoxazole or sulfadiazine may be given in doses of 6 to 8 grams daily, and ampicillin, erythromycin and streptomycin is used in advanced cases. This is also a drug to be used in toxoplasmosis. So combination of pyrimethamine and sulfadiazine is the treatment of choice for toxoplasmosis, as we have seen in the pathway that sulfadiazine or sulfur drugs block the first enzymatic conversion. Pyrimethamine also blocks the last enzymatic conversion and last two steps of that pathway. So the combination of these two is shown to be more effective. Now you have topical use also for these sulfur drugs. So you have for eye infection, you have sulfacetamide. For burns, silver sulfadiazine and mefenide. So these are the topical uses in burn cases where chances of infection is again quite high. Now these drugs are again, though they have advantages, the limitation is the development of resistance, and the adverse effects or adverse drug reactions which are known for these drugs are urinary tract related. That means crystalluria, they get deposited. There may be hematopoietic system related effects, which may include acute hemolytic anemia, agranulocytosis, aplastic anemia. This group of drugs are also known to show hypersensitivity reactions like Stevens-Johnson syndrome, exfoliative dermatitis, and photosensitivity. So, long-term use of this drug is also known to produce fulminant hepatic failure, hepatomegaly, and jaundice. There are some other reactions which may be seen like anorexia, nausea, vomiting, kernicterus, and drugs like mefenide or topically, which is one of the topically active sulfur drug, if applied on a larger surface area and tends to get absorbed, since it is a carbonic anhydrase inhibitor, so it tends to produce metabolic acidosis. Now there are certain drug interactions which are known for these drugs, which include interaction with drugs like oral anticoagulants, sulfonylureas, and phenytoin. When they're given along with sulfa drugs, you see sulfonamides, they displace them from the albumin. Since these drugs, all sulfonamides also bind to plasma albumin, so they compete for binding and displace these drugs. So accordingly, one has to either change the doses or change the drugs so that such an interaction could be avoided in the users of these drugs. Then you have interaction taking place with methotrexate. Sulfonamides displace methotrexate from plasma albumin, and also it decreases the renal excretion. So you see the displacement of methotrexate and decreased renal excretion is likely to produce toxicity related to methotrexate. So one has to adjust doses when such combinations are to be administered. Now you have another drug which is a combination of two, that is 4-trimoxazole, which combines two drugs which act sequentially on the pathway. This is this sulfamethoxazole acting at the first enzymatic level, and trimethoprim affecting the dihydropteroid synthase, the second enzymatic conversion. So the combination has dual beneficial effect. So the antibacterial spectrum includes Staphylococcus, Streptococcus, Salmonella, Shigella, Enterobacter, Klebsiella, Brucella, Pasturella, Yersinia, and methicillin-resistant Staph aureus. So now when such a combination is effective and produces more is more effective, there is a ratio which has been determined where this combination is most effective. You see the sulfamethoxazole and trimethoprim, when combined, when given at a dose of 5:1, they produce plasma concentration which is 20:1. So dose of 5:1 is the recommended dose to produce plasma concentration 20 in a ratio of 20:1. So this is the most effective combination, or the doses in which these are combined to produce maximum beneficial effect. Now where this combination has been used, this combination is used in urinary tract infections, especially lower urinary tract infection, bacterial prostatitis, and in respiratory tract infection like chronic bronchitis, otitis media, acute maxillary sinusitis. Now, in gastrointestinal infections also, this is given in shigellosis and in sensitive strains of Salmonella typhi. And it is also effective in infection by Pneumocystis jirovecii. Now, this combination is again not free from various adverse reactions. So, this may produce dermatological reactions, some sensitivity, hypersensitivity reactions. Then in GI, one may come across nausea, vomiting, glossitis, stomatitis, and then CNS reactions may include headache, depression, hallucinations, coagulation disorders. There may be granulocytopenias, agranulocytosis, purpurea, self-hemoglobinemia, where the oxygen carrying capacity of the hemoglobin is reduced. There may be impairment of renal functions and hypersensitivity reactions in AIDS patient as well, which may include rash, neutropenia, Stevens-Johnson syndrome, and pulmonary infiltrates may take place. So as overall, if we look at that, in certain conditions, this is the drug of choice, but in most of the other conditions, you have better agents available. So and in view of the resistance that develops to the use of these drugs, their use has become restricted, and you have other better antibiotics available. But when you come across sulfonamides, I think you will come across another sulfonamide which is a para-aminobenzoic acid derivative. So you have two moieties of para-aminobenzoic acid that forms dapsone, which is used in the treatment of leprosy. So I think with this we have almost covered the major points in this topic, and I just stop here.